welcome from GAPIO and from the dietetics colleagues of us. We have been organizing multiple sessions involving dietetics and has been benefiting a lot of audiences throughout the world. Today, we are having a session on sustainable nutrition interventions in critical care. I'm not an expert on nutrition, but yes, of course, sustainability is something which is key in multiple things. Any step you take forward, you have to ensure that these steps are sustainable, and same goes true with nutrition as well. Because if there are multiple, especially this is pertinent to when we talk about India, because sustainability in India is governed by many other factors like cost, like public education, availability, wide geographical area. So all these things do affect sustainability, and when it comes to nutrition, we have to ensure that the nutrition we are providing is sustainable. It's absolutely out of the topic of nutrition, but that's how I'm setting the context. And then I hand it over to Ms. Sandhya to carry it forward.
I'd like to, before that, I think Dr. Jain, I'll give a warm welcome to everybody. So I, Anita Jatana, consultant dietetics in the Trust of Delhi, would like to extend a very warm welcome to our esteemed speakers, moderators, and participants for the another GAPIO session. You just heard the details of it from Dr. Jain, who's given a very nice short script of sustainability in India. So today's session is very important, and we have absolutely welcome Dr. Mohammed Rehan Sayeed. She'll be joining in a little later. Some emergency surgery for him, who he'll be speaking on breaking the malnutrition cycle, sustainable nutrition interventions. And we have Dr. Meenakshi Bajaj. I don't think she needs an introduction to the dietitians here, but she's a dietitian in Tamil Nadu government multi-super speciality hospital, who will enlighten us on a very interesting topic, road to recovery, MNT in heart transplant. So something that we'll all be looking forward to. Then we have Dr. Avantina Bhandari. She is a culinary nutritionist who will be speaking on another important aspect in critical care patients normally overlooked by all of us. She's going to be talking on role of emotional well-being and sleep initiatives, something new that we are looking forward to. And we have Sandhya Pandey, General Manager and Chief Dietitian Medanta, and we have Anjana Nair, Consultant Nutritionist Bangalore, who will be moderating the session. So malnutrition, I think it's no new word to us as nutritionists. It's a huge problem. And I think we all know at admission in hospital, at least 1/3 of the patients have some degree of malnutrition, and 2/3 of them worsen during their stay. That, of course, we dietitians are responsible. And in ICU care, in hospitalized patients within the critical care setting, the global health problem prevalence is as high as 78.1% in the developing countries and 50.8% in the developed. A little behind us, but then. And consequences, I know, are huge, with significant clinical and increased economic costs, including risk of complications, infections, prolonged hospital stay, poor quality of life, and frequent readmissions. And it's more in the elderly. Reasons are metabolism increase, which increases by 25 to 50%, and in presence of sepsis, it exceeds 50%, leading to a protein loss of 10 to 15% and weight loss of 5 to 10%. So those are the huge implications. And there's also a study of ICU patients which found that 45% had mild malnutrition, 48.5% had moderate, and 9% of patients had malnutrition, severe. And reason is delayed feed procurement and feeds being held procedures. NBM from morning, NBM 24 hours from midnight. So we as nutritionists should aim for early nutrition initiation within 24 to 48 hours of ICU admission, and slow or delay EN only in case of GI bleed, risk of aspiration, intestinal obstructions, or risk of refeeding syndrome. So assess team, all of you, use any nutrition tool, MUST, MNA, NSR 2002, SGA, etc., and intervene timely with appropriate nutrition, starting slow, but gradually achieving targets. So hoping we are going to have more advancements, and been hearing a lot about muscle monitors such as ultrasound, CT scan, and DI, which will be utilized to assess nutrition risk and monitor response to nutrition. So the multidisciplinary approach with medical team, nutritionists, and physical therapists. Over to you. More power to the ICU team. So we have the entire team here today. So let's see what changes we are going to do. So moving forward, over to you, Sandhya, to take this program forward as the moderator.
Thank you so much, Nita ma'am. I think the stage has already been set. Thank you, GAPIO organizers, for inviting me on this wonderful platform to be the moderator. And I think this scientific session is extremely important for the practicing clinical dietitians, because they're always and constantly looking for simple, doable, practical solutions to sustain interventions in critically ill patients, and thereby helping in improving the clinical outcomes. And what better platform to have such eminent and wonderful speakers that we have for this. I would encourage all the participants to actively participate by putting in their questions in the chat box throughout the session, and our esteemed speakers will address them towards the end of it. Since Dr. Meenakshi probably is not going to be staying for the entire session, we'll take her questions immediately after her session completes. And then I would share the thought for you all to keep intrigued until the end. What if a simple shift in nutrition protocol and strategy could mean a difference between survival and a remarkable recovery? Because our doctors will ensure that the patients will survive, they'll go out of the ICU. But it is up to us to give the quality of life that they're looking for. And that's where the big question of having ensuring that they don't lose muscle mass, we start looking at sarcopenia, we start looking at their overall general health. So it's not just survival anymore. So stay with us to uncover these transformative possibilities. With this, I would like to welcome Dr. Meenakshi Bajaj. Like Anita ma'am already said, that she doesn't need an introduction. She has more than 30 years of experience in the field of healthcare. And she's not just a registered dietitian, but she's also an author, reviewer, and columnist. And she's written a lot of books. In fact, we've been referring those books for our own, clinical practice. She has been a member of various prestigious associations, has been giving input. And of all the things, I find her a wonderful speaker. The way she connects with us is remarkable, and her clinical practice is reflected. So I would not be taking any more time. Dr. Meenakshi, we're all eager to listen to you.
Thank you so very much, ma'am. At the outset, I'm truly grateful to GAPIO, Anita ma'am, as well as you for the warm introduction. And without much ado, just give me a moment. If you've given me the rights, I'll share my presentation.
Yes, we can see.
Yeah, okay, great. So the topic of today's discussion would be how we managed medical nutrition therapy in a cardiac transplantation patient. So one needs to understand that cardiac transplantation is a gold standard procedure for patients with advanced heart failure who are refractory both to surgical or medical management, and most unfortunate part being they have a very poor short-term prognosis. That's when they are considered as eligible candidates for cardiac transplantation. In fact, according to NOTO 2022, we've had almost 16,004 heart transplants in India. And it's interesting to note that in 1967 was the first heart transplant in South Africa. And that particular patient survived only for 18 days. And the first transplant in India was in New Delhi at AIIMS by Dr. Venugopal, after which then it's history that we have so many heart transplants. And it's unfortunate that the number of heart transplants have increased tenfold in the country. And another sad part about the transplant entire gamut is that there is 1 year survival of 84.5% of them and 5 year survival of 72.5% of them. This is a case which I will be taking you through in the next 15 to 20 minutes. Forgive me if I'm going to be rushing a little bit because it's difficult for me. Sorry, some tech error. So when we talk of heart transplant, the case which I'm going to be discussing to you is more associated with the, the patient having New York Heart Association class 3 and 4 symptoms. When I say New York Heart Association class 3 and 4 symptoms, on the right-hand side of my slide, it very clearly depicts the fact that this particular patient is with cardiac disease, resulting in inability to carry on any physical activity without discomfort. For example, even removing his shirt or, just getting up and trying to walk and go to the washroom, something very, very small also gives him discomfort. And symptoms are present even at rest or even minimal exertion. So that's considered as class 4. If any physical activity is undertaken, discomfort is increased. So this is as per New York Heart Association 2023 guidelines. So what are the causes for heart failure? If you see, it could be something as uncontrolled hypertension, uncontrolled diabetes, arrhythmia, renal failure, cardiomyopathy, CAD, who's been consuming alcohol, tobacco chewing, a raised BMI, and a left-sided heart failure can actually cause a right-sided heart failure. And another important marker to tell us whether the patient is in heart failure is the investigation done, known by name NT. Can you hear me? Am I audible? Okay, the investigation is by name NT-proBNP, which is, if it is abnormal, it is to be higher than 125 pg per ml, and it is usually accompanied by symptoms or signs of the disease. In elderly patients, with reference to the United States, the threshold is more than 450 pg per ml, and it's interesting to note that there is an inverse association of NT-proBNP with diabetes in females. Females with diabetes were less likely to have NT-proBNP above 125 pg per ml threshold. Moderate lifelong elevations of BNP protect them against type 2 diabetes. So basically, we have two things in mind. One is the NYHA classification. There is also a Ross classification 3-4, which is mainly for pediatric population. I am talking to you about the adult population. And next is the NT-proBNP. So whenever there is heart failure, you need to understand what are the types. It's left-sided, right-sided, or high output. And as Anita ma'am and Dr. Sandhya were very, very clearly, making a mention of how important the role is of a nutritionist to prevent malnutrition, a patient who has walked into the hospital and walking out of the hospital. Because as Anita ma'am clearly mentioned that at the time of hospitalization itself, they are undernourished and they walk out of the hospital. It's our duty to see that their BMI does not compromise any further, unless and until there is an indication for it. So basically, when you look at heart failure, there are two sides of heart failure. One is the patient can be obese. The second side is the patient can be underweight. The third thing is he may or may not have lung involvement. When I say lung involvement, he may have COPD along with congestive heart failure, or he may just have congestive heart failure with a CAD or any other related cardiac disease. And third important thing is usually whenever he walks into the ICU, congestive heart failure patient, he usually comes with symptoms like breathlessness, and sometimes there could be dyselectrolytemia. He could have aspirated at home because of dyselectrolytemia, like something as small as hyponatremia. He could have been drowsy. The patient's attenders would have tried to push some food into his mouth and he would have aspirated. So pulmonary aspiration, pneumonia, drowsiness, breathlessness, even orthopnea, sometimes with ascites, without ascites. These are all common symptoms of congestive heart failure. So when the patient walks in like that, then they do an NT-proBNP and then the investigations move on. So what is the management of heart failure? You could have pharmacological, surgical, nutritional management like any other condition. Nutritional management it goes without saying, it has to be a customized approach. The standard dictum for a congestive heart failure patient is whether he's A, B, C, D. There are 4 stages of heart failure. In that, they talk most importantly of DASH diet. I don't think the present audience requires me to discuss what is DASH diet. But remember one more thing with reference to DASH diet, though we know there is an improvement in dyslipidemia, cardiac function, quality of life improves, blood pressure improves. All of this is part of implementing DASH diet in the patient's diet. But if the patient is on SGLT2 inhibitors, like he's on, he's just moved from 1 to 2 stage or 2 to 3 stage, still he's not an eligible candidate for heart transplant. He's put on SGLT2 inhibitors, and these SGLT2 inhibitors are very, they are naughty in the sense that obviously their job is to push out a lot of fluids from the system, not allow sodium to be reabsorbed, not allow glucose to be reabsorbed. So these patients are at high risk of hyponatremia and hypoglycemia. So check out on the 24-hour recall and then decide whether this patient is ideal patient for a DASH diet. Otherwise, just don't directly jump into a DASH diet. DASH diet is important with reference to no sodium rich foods. But the reference to the amount of salt which we want to push into the patient's entire day's diet, that will depend on his serum sodium value, whether he's got fluid retention in the form of edema, pleural effusion, ascites, body anasaka. All of these things will allow us to give some insight whether the patient is truly hyponatremic or it is pseudo hyponatremia because of fluid overload. So as Anita ma'am already made a mention, there are a list of tools. You can choose whatever is appropriate for your patient. It could be GLIM criteria, or it could be NRS 2002 along with Nutri-Score, or simple mini MNA if the patient is a geriatric patient. So the list goes on. You have to decide what sort of screening and assessment tool would be appropriate for your patient. And in fact, there is an important component called prehabilitation and rehabilitation also when it comes to solid organ transplants. So that's a 1-hour lecture by itself. But keep that in mind that there is a component called prehab and rehab, pre and post solid organ transplants. So as a nutritionist, what is my job? And my patient is undernourished, to pick up the nutrition status slightly, because here obviously we are looking for cadaver transplants. We are not looking for a live donor. It's common sense. So the patient is in waiting for 4 months, 5 months, 6 months. So we have enough time to improve the BMI to either, reduce the weight or help in weight gain. Second is, obviously we want blood pressure control, and there is associated component of dyslipidemia, improved dyslipidemia with diet and medication. And the most important thing is keeping in mind the sodium, potassium, and the fluid. Now, why the potassium component comes here? If the patient is on a diuretic, which is a potassium sparing diuretic or potassium losing diuretic, we have to keep in mind the serum potassium values. Prevent overfeeding or refeeding. That will come after, on admission, if the patient's BMI say 14 or 15 and your target is at 25 to 30 calories, patient is consuming only 10 to 12 calories. You can't push 20, 25 calories. You will definitely be pushing the patient to hypertriglyceridemia, hyperglycemia. The patient can have further dyselectrolytemia. So we need to be very, very careful. We are dietitians. Okay, we want to improve the nutritional status, but we don't do it overnight. So preserve lean muscle mass is important. Usually, if you see a patient with a congestive heart failure who is accompanied with COPD, believe me, to feed the calories is a project. So if the patient is enterally fed, okay, we can easily achieve, say, 1,000, 1,200 calories without any worry. But orally, when the patient is consuming an oral soft diet or a liquid diet, he's more comfortable taking liquids. And usually, congestive heart failure goes hand in hand with fluid restriction. So with fluid restriction, then we need to think of oral nutrition supplements, which are 1.5, 1.8, 2 kilocalorie per ml. And we can meet some decent calories in order to have some muscle strength for the patient. Otherwise, the patient is going to lose out on muscle when you're not going to give adequate calories. It's nice to say you need to do a rehab for such patients. But believe me, these patients who have dyspnea and orthopnea, very difficult for the physiotherapist to work with them. And they are having, abdominal distension because of ascites or pleural effusion, which is not allowing them to be physically active. That also worsens the component of sarcopenia in such patients. Now, this is a recent 2024 paper which talks to us about salt restriction, MCT, beta-hydroxybutyrate, ketone esters, coenzyme Q, resveratrol. But I'm very, very apprehensive when it comes to a ketogenic diet. They also talk of not only Mediterranean and DASH diet, but also ketogenic diet. I am worried about it because when we talk of ketogenic diet, we are actually pushing a lot of fat, and most of it, the fat is saturated or MCT-based fat. The saturated fat is not going to do any good to the dyslipidemia component for my patient. So I'm a little worried about ketogenic diet, but I think we need to look up some more larger studies to make a recommendation with reference to ketogenic diet. Yes, okay, there is some more data to tell us that we need to provide the patient with beta-hydroxy, beta-methylbutyrate, that is 3 grams per day, omega-3, 1 gram per day. Protein will depend. Now, when you are having 1 liter of fluid restriction, invariably you will see such patients with mild component of uremia. And if you are going to push protein and fluid is restricted to about 1 liters, you may be worsening the uremic status. Unless and until, the cardiologist team is ready to do renal replacement therapy, then probably we can push such high protein. Otherwise, It is like a day-to-day calculation which we need to make based on the renal profile. The calories will be 22 to 30, but I'm still very, very uncomfortable with this 22 to 30. It's usually between less than 25. So you may land up only with 20 to 22, and that's more than enough. And remember, the more the simple carbohydrate you push the patient with, because they're more comfortable with liquids. So they prefer juices, soups, and porridges. So soups are still okay, but juices are not okay. Porridges, if they're cereal-based porridges without complex carbs, they are going to increase the carbon dioxide production and going to worsen the exacerbation they already are having if they have a component of COPD. So obviously, importance of nutritional status, we are aware. We need pre, post, during, and after follow-up also is very, very important, because after we have discharged the patient after transplant, obviously the first 6 to 12 weeks is very, very critical. After that, the component of drug and nutrient, not only after that, drug and nutrient interaction is very important immediately post-transplant, at discharge. Then another important component being the new onset of adult diabetes, that is secondary diabetes due to the immunosuppressants the patient is provided. So let us come to the case. It's a very interesting 26-year-old male who was smoking 20 cigarettes a day for 6 years, consuming alcohol for 4 years. He had a very sedentary lifestyle. What was his dietary pattern? Now, before I go on to that dietary pattern, I'll make a small mention of his past medical and surgical history. Nil surgical history. Medical history, he did have gastric ulcer, cardiac events, hypertension, on and off pricking chest pain, on and off vomiting, breathing difficulty, orthopnea, pitting edema of both the lower extremities. So we know here there is gross fluid overload. So we need to keep in mind when we are calculating the BMI of the patient, we need to deduct at least 15% from the present body weight to get the dry body weight. Now, what was his past medical history? He had CAD in 2013, anterior wall MI in 2016, followed by an inferior wall MI. When he came to us, he had dyslipidemia, elevated liver enzymes, and uremia. So the diagnosis was CAD, CHF, NYHA 3-4 classification. Ejection fraction was only 25% with mild renal impairment and congestive hepatopathy. Now, I'll tell you why this congestive hepatopathy. Mostly when I used to see the cardiac failure patients initial days, I never ever understood why there was a raise in the bilirubin or the liver enzymes if the patient is a non-alcoholic or no hepatitis B or hepatitis C. No, none of those risk factors, but there is a raise in the bilirubin, which tells us very, very clearly that there is hypoperfusion to the liver. When the heart is compromised, the liver also gets compromised. The reason being there is congestive hepatopathy and the raise in liver enzymes. So obviously such a patient who had fluid overload had anorexia. Hunger, I would not call it normal, but actually suboptimal. Thirst was normal, bowel was normal, micturition was oliguric. So that also tells us that fluid was an issue with this particular patient. What was his weight when he came to us? When he came to us, he was 110 kgs. Now, don't look at the 110 kgs, 10 kgs, look at it directly as body weight. Remember, I told you he's got body anasaka, he's got fluid overload in the form of bilateral pitting edema. And because of this fluid overload, we need to deduct at least 15% from his present body weight. So we got the dry body weight as 93 kgs. Based on this dry body weight, his body mass index is 29. Now, our job is we have at least 4 to 5 months. 1 month, say we can say, you know, he may be very lucky, he may get a donor in 10 to 15 days, or he may be unlucky, he may have to wait for 5 to 6 months. And in that 5 to 6 months, we may also lose the patient. But this particular patient, we had him with us. He was with us for almost 5 months prior to transplant. And it's interesting that I want all of you who are here to also read about the green corridor, because the time is short. I may not be explaining green corridor, but read about the green corridor when it comes to solid organ transplants. So his ideal body weight was 79. He was not a diabetic. That was only blessing in disguise. I mentioned to you liver enzymes raised, mild urea creatinine raise, and dyslipidemia, and there was hyponatremia. This hyponatremia was because of fluid overload, and there was a raise in the NT-proBNP. Now, nutritional history. This is very interesting. The whole day he was actually not eating anything. Breakfast and lunch would comprise only 20% of his total energy intake, whereas he would consume 1 liter of a carbonated beverage every day with half liter of alcohol every day. And his meal used to be only, you know, refined flour-based paratha with mutton kurma. In South India, mutton kurma is usually made with a lot of coconut in it. And the paratha is made with a lot of edible hydrogenated fat. So it's maida, edible hydrogenated fat, coconut, and red meat. Along with that, the carbonated beverage of 1 liter through the day he used to take, alcohol at dinner time. Now his calorie intake was as high as 3,000 odd calories and fat consumption was as high as 123. The 234 grams of carbohydrate is not coming from the alcohol yet. I have not put the alcohol carbohydrate. If I touch the alcohol carbohydrate, it becomes 334 grams per day. So now I'm having 3,000 calories. So I have to bring down the 3,000 calories. I cannot feed him so much. And actually at time of admission, he was not taking 3,000 calories. He was consuming around 2,300, 2,400 calories, much lower than what he used to consume on regular basis. So we managed to pull him with 25 calories, less than 1 gram protein. Why? Reason being because there was a component of uremia. Fat obviously coming down 60%, carbs, fluids is urine output plus 500, mostly 1 to 1.2 liters was his requirement per day. Now, most important thing you need to remember, we cannot push too much of energy intake, not only because of hyperglycemia, which can become a component, but all this while he was not a diabetic. So we don't have to actually worry with reference to calories and diabetes, but there's an increased risk of cardiac failure decompensation. So we can't give too much calories because it will decompensate the cardiac failure further. Now, pre-operatively, we managed him. We pulled him down. He lost almost 25 kgs weight. So this 25 kgs weight was not only through diet, but also through fluid overload, which did come down. So our short-term goals, we managed to get his weight in place, managed to get his BP, fluid overload, dyslipidemia, elevate his symptoms, improve him slightly better. So he could do a little bit of walking in the department. Long-term goals was we wanted him to walk out comfortably without, any post-operative complications, though that's not in our hand. We are only a drop in the ocean, but as always, I make a mention that if there is a rotten tomato in the basket of tomatoes, I'm going to use the entire basket of tomatoes for a large bowl of soup. The entire soup is going to get ruined. So similarly, this drop in the ocean, that is the medical nutrition therapy, also plays an important vital role when it comes to dyselectrolytemia, when it comes to hypoglycemia. All these are very important critical key areas which need to be handled by the dietitian, including the fluids, and provide adequate carbohydrate in order to prevent starvation or nutritional ketosis. So we managed to pull the patient well. Okay. After that, important component of science is, do we do ERAs with reference to carb loading in a cardiac transplant patient? No, we do not do, because there is not enough evidence for that with reference to heart transplants. Now, the procedure took almost 4 hours, 8 minutes. And after surgery, I think the third day itself, the patient passed not regular bubble, but at least some amount of bubble he passed. And we extubated the patient in less than 24 hours. We started clear fluids. Usually we start the patient with a glycemic friendly supplement, even if the patient is not having hyperglycemia. Most patients, 80% of the patients have hypokalemia post-transplant. Some patients are unusual, they have hyperkalemia. So you need to adjust the supplement accordingly and the diet. And most often, day 1, day 2, they are very happy with full fluid feeds, taking very, very small quantity of soft solids. So we are not able to meet the calorie requirements at all. It took us almost 7 days for us to meet the calorie requirements. Okay. Now, as I mentioned to you, while we were taking care, another important component, what comes with heart transplant as a package, it comes 1 + 1 free, is there is some component of AKI in the first few days. It's not full-blown AKI requiring renal replacement therapy, but the urea creatinine is slightly on the higher side. Within a week or 10 days, we do usually see the resolution of urea creatinine to normal values. So now everything progressed well. We started with clear fluids, transitioned to semi-solid diet. By 7th POD, we reached almost a near normal diet, and 16th day, we discharged the patient. Now, at the time of discharge, he gained 2.5 kgs. So at time of surgery, he was 85 kgs. And after surgery, without fluid overload, he gained almost 2.5 kgs. Now, this is okay with us because we don't want him to lose muscle mass. I would allow him 6 weeks, maximum 10 weeks on, say, 25 to 30 calories, but not more than that. 25, I think, was good to go with because his BMI was 26. Now, after 12 weeks, I have no choice but to bring him down to absolutely a lifestyle modification diet, wherein he should not develop DAAD. He should not develop diabetes because of insulin resistance, obesity, because of the immunosuppressant. So my aim is, after discharge, I will take care for about 8 to 10 weeks, feed him quality calories even after discharge and follow up, but be very, very careful and critical after 12 weeks that he does not gain weight at all. So that's my important goal, which I need to keep in mind. Now, post-transplant, I need to remember what is the drug and nutrient interaction. Most often with cyclosporin, you will see dyselectrolytemia, hypertension, diabetes, weight gain, excessive hunger. You're not supposed to give grapefruit juice. And importantly, when you put the patient on corticosteroids, there is a component of gastritis. I forgot to make a mention. During the entire post-transplant phase in the ICU, he did have hyperglycemia, wherein we had to start insulin for the patient. So hypoglycemia is also another important component which we need to keep in mind. So patient was discharged, very happy, all went well. Now at discharge, I told you we can give between 25 to 30 calories, and we did make a small restriction in his potassium because his potassium was slightly raised at the time of discharge. Remember, at the time of transplant, there was hypokalemia. We put the patient on pot chlor, which gives a very metallic taste. It makes it difficult for the patient to take normal diet, in terms of quantity or frequency because of the pot clot. But at the time of discharge, because the immunosuppressants start doing their job, there was a slight component of dyselectrolytemia like hyperkalemia at discharge. So keeping that in mind, there was moderate potassium restriction in his diet. So wherever required, we did make a mention of leaching because, that kept the potassium slightly on the normal. Now, what was the bigger problem was 5th day we had him readmitted. Why did we have him readmitted? Because of cardiac tamponade. And cardiac tamponade is a condition where it could be because of a stab injury, or it could be because the patient had an MI, or it could be just a post-operative status where the patient would have had a cardiac tamponade, which means fluid gets accumulated around a sac, and that prevents the ventricle from doing its function. So this is the problem. He came to us the 5th day with terrible breathlessness, and he had to undergo a pericardiectomy. So another major surgery. Now, what do we do? Here, the biggest challenge here was he had to undergo renal replacement therapy because he came with a component of AKI. He walked into AKI when he came into our ICU at the time of admission. So the entire gamut is now we have to manage AKI and post-operative status. And remember, he became a diabetic. He was put on insulin at the time of discharge. So this time it took us, last time it took us only 7 days to achieve the target. This time it took us 22 days to achieve the target. But there was another component of nocturnal hypoglycemia this time. Always remember, a renal failure patient who undergoes dialysis, he is at high risk of hypoglycemia immediately post dialysis. But this particular patient, his appetite took really long for us to, sort him across. So he had nocturnal hypoglycemia. So we had to adjust his insulin dosage, and he was put on a very small dose of anti-diabetic agent at the time of discharge. And this time he got discharged 45th day. Last time it was only 16 days. This time he got discharged after 45 days. But when he came to us this time, he came to us with AKI, with the fluid overload, as well as the cardiac complication, and he developed folliculitis. Folliculitis tells us very, very clearly that if the hygiene of the patient is not very, very good, he may be at risk of developing such infections, dermal manifestation. So importance of post-transplant is hypertension, excessive weight gain, dyslipidemia, osteoporosis, because the patient is on corticosteroids and risk of infection is very, very high. Usually we lose such patients post-transplant during the cold, fever, flu season. So most often these patients, they don't come back to you in time when they're running high fever, cold cough. That's the time when most of our heart transplant patients we have lost. So keep in mind, food safety is important. Immunosuppressive drugs do their job. So, but our job is to talk to them about food safety, food hygiene, and not to gain further weight in order to prevent further complications, metabolic complications. So this is all we did with reference to the diet. And at the end of 1 year of follow-up of this patient, his BMI reduced from 29 at the time of admission to 25 at the time of discharge and now 20. So his BMI is currently 20 and he achieves 9,000 steps. He's doing fairly well, and we just hope and pray he lives long. So that's all about this case, which I wanted to discuss to you in about, say, 20 minutes. I hope I've taken the right time. Thank you so much for the patient listening.
Thank you, Dr. Meenakshi. You indeed nailed it yet again. You covered all the aspects of the transplant, starting from rehabilitation to the entire surgery, pre-operative and peri-operative surgical care, and till another 1 year of the patient's management. Few quick questions I would want to ask you. Transplants, as soon as we hear about transplant, we say neutropenic diet. Very quick thing for all our dietitians. For how long would you recommend neutropenic diet? Is there any relevance anymore, any longer? So what is your take on that?
See, neutropenic diet is, I would say you and me also should take a neutropenic diet.
Yeah, right.
It's as simple as that.
Basically,
so
yeah.
somebody who's on an immunosuppressive therapy for life, what do you think he should be on? He should be on a pseudo neutropenic diet. So basically, if he eats home cooked food, home prepared stuff, I think it's more good to go and eat fresh food, eat cooked food the moment it is cooked to consume it. Usually we do not allow our patients to take fruit juices because of hyperglycemia and stuff like that. We usually tell them to take a fruit and take local and seasonal. If you don't go local and seasonal, you're in trouble. That's point number one. Whatever fancy it may be.
Yeah. Hygienic food practices, right?
Yes, simple.
Absolutely.
So there are two questions there in the chat box for you, Sandhya.
Yeah, absolutely. I'll take that. But quickly, also your patient was discharged. The first time the patient was discharged, what was the protein recommendation? Because post-operatively or surgical transplant patients, you're worried about sarcopenia.
This is a very interesting question. See, your requirement is 1.2 to 1.5. Okay,
Yeah.
post-transplant. But I will tell you one thing. I work in a government setup. So we were pushing this patient with enough of oral nutrition supplements to meet our target. So we managed to meet our target. In 7th day itself, he was taking a normal consistency in terms of frequency, quality, quantity, all of it. We were able to manage it. But without oral nutrition supplement, it's not possible. Point one. Point number two, I had a major discussion with our cardiac surgeon. He was against me providing oral nutrition supplements completely. And my argument was, I want my patient to recover. You cannot tell me or hold me not to give oral nutrition supplements. And believe me, in a government setup like ours, we are allowed only 50 grams per day of oral nutrition supplement. That's not enough. It's part of the package that cannot go cross 50 grams. So we beg, borrow, we don't steal. We beg, borrow and ask, request our donors to help us with supplements for such special patients. All that we are doing, we're giving 100, 150 grams the initial first 3-4 days to prevent sarcopenia and all that stuff. His argument was,
quickly, your AKI resolved post-operative.
The important component is, he says that when you are putting the patient on immunosuppressants, they keep measuring the serum values to keep adjusting the immunosuppressants, right? And that is directly dependent on the calorie and protein you are consuming. So provide a diet at time of discharge, which the patient can consume at home, which he can afford at home. Because if he cannot afford at home what you are providing here, his values are going to be deranged and either there will be rejection or there will be trouble. So this was a very, very big challenge for us, that at time of discharge, though the books tell us 1.2 to 1.5, we managed it till he was with us 16 days plus 5 months prior to that. But uske baad, we find out from the patient, can you afford? And as a dietitian, I'm not supposed to prescribe a nutrition supplement to him. That's also against the rules. So we have to do it in a very catch-20 situation and find out from the patient how much can he take.
True.
So he could match only 1.2, not 1.5.
And I'm not even talking about the HMB and omega-3 here. I would take
all that is, it's nice to know that yes, these components are there, we can use them. But believe me, it's a little difficult in a low resource setting.
So I think we are short on time. Quickly, the questions. There is one question by Rashmi Srivastav. Dietary suggestions to reduce NT-proBNP in paralyzed female patients on thyroxine, metformin apart from
how we can reduce? Only SGL2 inhibitor can help. SGL2 inhibitor If the patient is not in 4, classification 4, SGLT2 inhibitor will help the patient with the amount of sodium restriction, fluid restriction, and being a lifestyle modification, Mediterranean, pseudo-Mediterranean Indian diet, a healthy diet basically, will help to reduce the symptoms of cardiac failure and may help to improve NT-proBNP. Definitely.
Absolutely. And Shivani here asks, are fruits ready to be totally avoided? Which all fruits can be given in neutropenic diet? I think
Why? No.
So Shivani, very clearly, you can allow your patients to eat all fruits. Just make sure that it's freshly cut and it's safe and hygienic. That's all. And Kajal Yepto and Jyoti Arora are really happy with your presentation. Thank you so much.
Very much. Thank you so much.
Thank you, Meenakshi. Big thank you.
Thank you.
And welcome to Dr. Rehan. I do understand you had a surgery, so over to Dr. Sushil to introduce him.
Thank you.
So welcome, Dr. Rehan. Dr. Rehan is an eminent cardiac surgeon with 20 plus years of experience. He is the founder of the Motherhood Group of Hospitals, which is a leading chain of mother and child care hospitals in India. He is an avid researcher with many firsts in the field of cardiac surgery, and now is focused on helping the community with better nutrition supplements that deliver as promised. As an apart from that, the flip side, he is an elite athlete himself, and he is a national medalist and has represented the country in the sports of rowing at many international leagues. His passion for sports has driven the sports nutrition vertical for us. So welcome, Dr. Rehan. Just to tell you, I had been part of the cardiac surgery unit for 14 years. Now I am into admin, so cardiac surgery has been close to me. So over to you, Dr. Rehan.
Thank you so much. Let me just first try and share my presentation. Can we all see it?
Yes, sir.
Yes, we can. Yes, we can. Yeah.
Okay. Let me just get started then. All right. So I was just joined in a little late, and I was listening to the presentation from the previous speaker briefly towards the fag end, and I saw that one of the I can't agree more with her on the fact that we have no control on some of the nutrition that patients take once they leave the hospital. And this is exactly why, as a cardiac surgeon, it drew me towards nutrition as a whole, because I do a lot of minimal exercise. Logically, if you do something like that, patients should be getting up and running rather than, struggling to even walk or come back to you in the OPD in a better way. And so it made me sit back and think, what can we do? Are the existing products in the market not catering to our needs, whether it be in terms of content, whether it be in terms of cost? I don't know. I mean, it's still a work in progress. It's still something I'm passionate about and something that I want to fix. While we get into, so I'll run through the slides a little bit faster because I think Meenakshi, I'm sure, must have touched a lot upon what nutrition and things can do to a cardiac patient, which is basically what I would also have the maximum expertise with. And so when you look at the theoretical model in terms of any patient's behavior or anyone's behavior, they first start contemplating, what should we do? Then they think of, they have specific goals. They look at, should I prepare? Then an action plan gets put in place. Either a nutritionist puts it or someone puts an action plan in place for them nutritionally. And then they get into, actually trying and testing things out. What I have noticed in my career is that if you can, and you should, actually get your patients up to speed with nutrition before you take them up for surgery. If it's an emergency, if they have ischemia, you can't wait, it's a different story. But if it's possible, then if you optimize them even for 2 weeks or 3 weeks prior to taking them up, the outcomes are outstanding. My team, over the last 14 years, we run an ALOS of 4.2 days for a CABG patient. And we've been holding this A loss of 4.2 to 4.6 over the last, I think, 18 years of practice in this country. And the only thing that I do different from a lot of my Indian colleagues is that I have, right from the word go, had a very clear vision of how I want my patient to be nutritional, and how, if I find them depleted, if I can buy time, I buy time and then fix it before I bring them in for surgery. So there are a lot of trajectories like this slide shows. They come in, they go into the ICU. All of them need mechanical ventilation at least for a day, maybe 4 hours, maybe more than a day, some of them. Then that depletes them completely. Then you send them to the ward, they don't eat. What happens is we think that they are eating, right? We tell the nutritionist, I want 80 grams of protein, I want a 2000 kilocalorie diet, and I have only 1500 ml of water that I want my patient to get. All of that is given appropriately by the team, but patient is not taking even 20% of it. So in my opinion, it is not about just putting things on the table. I think it's important for us to also have what is known as a calorie count, because that is so important. That is actually what the patient is getting. Everything else is secondary. So we are under the assumption he's getting what, 2000 calories every day, but in reality he's not even getting, like, say, 800 or 700 calories a day, and then they keep getting calorie depleted and their recovery becomes slower and slower. And when you look at all the phases of that, they have a pre-critical phase and an acute phase of critical illness. Then they have around some chronic phase if they get stuck in the ICU. Then they recover from the ICU, go into the ward to some phase of recovery, and then discharge. And actually, this in India is a very long term. In the Western world, these patients go home and come back on the third day like they've not had surgery. But Indian patients, because of then a lot of nutritional superstitions and a lot of nutritional issues, it's difficult for us to get to achieve the exact same outcomes with them. And the risk factors that influence nutritional support in cardiac surgery patients, a lot of them elderly have pre-existing malnutrition. They are quite depleted. I mean, especially a lot of our vegetarian population are significantly protein depleted when coming to surgery. When you do their preoperative albumin levels in some of the chronic patients, they are even in the range of 2.73 or even less than that sometimes. So old age, comorbidities, not following proper guidelines, sometimes gastrointestinal atony, overall systemic inflammation, nutrition itself being bad as a whole, as I keep repeating it. And then again, then they come in for surgery. Sometimes, the surgery might take long, or they might have an extended ICU stay. And these people, if they don't go through the ICU like with no problems, then they can be a huge burden to you in the ward phase of the stay in the hospital. They end up staying much longer. And overall, if you look at even the economics of healthcare, any patient staying long in the hospital is going to be draining the hospital's resources, draining the family's resources, and also not getting better himself. So instead of getting them in a undernourished state, I would repeat again, it's better to get them optimized so that they fly through surgery effectively and comfortably. Very clear data there that malnutrition in cardiac surgery patient is directly related to very bad or worse outcomes. Those who are in chronic heart failure, cardiac cachectic, like people with chronic valvular problems, a lot of them are sarcopenic. There is hardly any muscle mass there for us to deal with. Very little functional or metabolic reserves. They come to us with low hemoglobin, high sugars, low albumin levels, and even overall a malabsorptive state is also what we see. They don't seem to handle any food that you give. There's some issue or the other. All of them have worse functional recovery, higher rate of infection, increased rate of ventilator-associated pneumonias or hospital-acquired pneumonias, increased A loss, increased ICU length of stays. They go home even if they discharge, they are usually within 48 hours, those who come back for readmission. And overall, this group has a higher mortality and morbidity compared to the others. I'll skip this slide because it's the same thing, but I think the take-home message from this slide would be the last two lines, where most of these patients are in hypermetabolic states. They are also in protein catabolism. They have, a lot of them have ICU-acquired myopathies or weaknesses, especially those who are chronically there in the ICU for a long time. And they also have a significant amount of insulin resistance. Overall, all this leads to decrease in the lean body mass, decrease in physical function, and the state of malnutrition. So what are our goals over there? We need to provide optimum energy by delivering the essential nutrients for recovery and healing. We need to manage fluid, acid base and fluid balance. Try to promote anabolism, boost immune functions, thereby staying away from hospital-acquired infections. Reduce or try to prevent muscle loss, optimize glycemic control, and overall ensure safety of these. All this leads to improved overall outcomes. I am a stickler for this, for proteins, for whatever reason. I believe that for a patient to recover, especially most of our long stayers or those who are stuck in the ICU for beyond 24 hours, the nutrition, not only in terms of calories, nutrition also appropriate amount of protein is important. Of course, we'll keep an eye on their creatinine levels. We'll keep an eye on how much of fluid that we can actually give them. But in those who have normal ventricular function and fluid restriction is not a problem, I think we would like to see a good amount of protein, at least, at least a 1:1 ratio, if not to the body weight, so that we can see our patients get better and faster. Protein intake, if it's less than 0.8 grams to a kilo, there are papers that suggest that there's a higher incidence of mortality and even higher morbidities very clearly than compared to those who receive 0.8 to 1.2 grams per kilogram body weight. While we talk about how much protein we want to give, as someone who's at the ground level, there's a question that I've always asked the nutrition community. It's not just about how much protein we give, it's how much is my patient actually assimilating. Because ultimately, if he's not assimilating that, it doesn't matter what I give him, it's not really making a difference to my outcomes. So I think that's where we rely hugely on, playing around a little bit with the total amount of protein that we give. Because if we find diarrhea, we trying to pull back a little bit and see, or we add, protein digestive enzymes, blends, we add pro and prebiotics and try to see how we can get these patients to accept and assimilate all the protein that we are giving them. So grossly, post-op nutrition goals will be, start nutrition. We start, if they can take orally, we start orally very early. If they can't take orally and we think they're not taking enough orally, then I put in a nasogastric tube and I start feeding them through a nasogastric tube. So I can control at least to some extent how many calories I'm giving them. The rest is whatever they eat is fine by me. Fluid restriction, if it's a normal ventricle, we are okay with up to 2 liters. If it's someone with a low ejection fraction, like say 35-40%, then we would stay somewhere between 1 to 1.5 liters. Low on salt, low on potassium, as easily digestible form of nutrition as we can give them in the early period. Adequate protein intake, and most importantly, an adequate amount of calories also, because there will be a significant, catabolic state, so they'll be burning a lot of them. We'll skip this one, and I'll take you to the key issues, because I think you would want to hear more from what I face on the ground than a lot of the theory. What we see in today's scenario is the average age of patients coming in, for surgery, even in India, has gone up significantly. We see a lot of octogenarians willing to undergo surgery if they feel that we can give them a good quality of life. But 75 is no longer an old situation to be in. So old age is there, poorly controlled diabetes is the norm, obesity on and off, COPD and smoking has become the norm, poor nutritional status is the norm. And if you go by the frailty index, frailty is also a problem. So overall, these patients do come also with some indolent infection, especially women will come with chronic UTIs or chronic cystitis, which further adds to other issues. We see a lot of loss of appetite, loss of weight, very little muscle mass, a lot of malaise, overall lethargy, and all this leads to prolonged recovery and cachexia for almost a month, sometimes from the date of surgery. And I think that's where we adding nutritional supplements or educating them on what kind of nutrition that they need to take has been a game changer as far as I see. My experience, and that's why I did play around with a lot of the key nutrients that I would want on board. Some of them I try to incorporate into on a regular basis into my practice. I think from all this list over here, there are two things that I would probably, two or three things that I would put as game changers for me. One is HMB. I think it's a game changer. I've seen patients do so well on products that contain HMB in some quantity rather than products that are just plain protein supplements. Also, the second thing is the digestive enzymes, or what I would call protein blending enzymes that help these proteins to be digested and assimilated. They play a key role because otherwise most of these patients have a significant amount of osmotic diarrhea and a good amount of probiotics also to help them get over some of this protein load that we are giving them and help the gut through with the absorptive state. The rest are probably supportives. CoQ10 in the USA is like rampantly used on all cardiac patients. Curcumin and glutathione are also good to have. But I think for me, I would reiterate the game changer, I think, is HMB. It is definitely making a lot of difference in patients who are on it and those who don't get it. And HMB, I think everyone knows about, so nothing much to add more about it, except that for me, I'm looking at the ability for it to reduce muscle protein breakdown and preserve muscle tissue and prevent muscle wasting. This is a game changer for us in terms of our patient outcomes. They do really well, and the frailty also is reduced significantly. And there are studies which show that the patients who are taken up for elective heart surgery 1 month prior to surgery, we have, there's a group of supplement versus placebo and things. And overall, there's clear data that's out there, very, very categorical data out there, which says that better preoperative nutritional status means better postoperative outcomes. Lesser the frailty, better the postoperative outcomes. Better the glycemic control, better the postoperative outcomes. And overall age is not the only criteria to decide the outcomes. If you have patients who have all these in the right order, even an octogenarian is a candidate for surgery without any issue. And that's what literature also says. You can optimize nutritional strategies and it makes a lot of difference. And the role of nutrition rehabilitation in recovery of survivors of critical illness. Nutrition is very under-recognized, very underappreciated, but it is the key element. I would say that a loss of 4.2 to 4.6 days is only because of two specialties in my hospital, my nutritionist and my physiotherapist. All of us surgeons do the same job. If one guy has a better A loss, it's only because he's able to drive these two verticals in favor of his patients. I think that's the game changer over there. And then ERAS is now a big thing, that is enhanced recovery and early extubations, early discharges. So ERAS is, if you want ERAS to happen, you want early shorter A loss, then you need to optimize all this prior to getting them in for surgery. And then there are some multidisciplinary statements on nutrition from cardiac surgery. But once again, like I repeat, you have better glycemic control, you have less frailty, and you have better pre-op nutrition, your outcomes are guaranteed. Rest of them is repetitive. I wouldn't want to bore the audience on this. So I can even stop here and take questions if you're okay with it.
Thank you, Dr. Rehan. And with the spice of your practical experience over the years, definitely helpful. So over to you for the questions.
So we cannot see many questions, but I would certainly, a wonderful session, Dr. Rehan. One question that pops in my mind since you said, say HMB is a game changer. And we have started talking about HMB in all our critical care patients. What is your experience? What is the dosage that are using? Because there are many polymeric formulas which have HMB as a part of it. They recommend 3 grams of HMB, which is not possible unless
Not possible. I was just coming to that. I think a gram of HMB a day is actually what I've seen make a categorical difference. But anything, I would probably say a gram a day in what I have tried on my patients. So once you get that 1 gram a day, then you can see a significant change in 2 weeks' time. I've had an 84-year-old, 87, 91-year-old I've taken to surgery, and they've all done well. But what I do is I put in a nasogastric tube and I start feeding them from post-op day 1, because I know they're not going to get enough intake if I depend on them, and then take it forward from there. And that's how I make sure that they get what I want to give them.
So your patients are not NBM from midnight?
No, ma'am. They're NBM from midnight for the surgery, but then after that, once post-op is done, the first post-op day, we start oral feeds, and usually it's the liquids and semi-solids. But if they're not able to take enough, I add.
No, Dr. Rehan, the carbohydrate loading do we do, which has been the ERAS protocol since so long, but none of the hospitals really want to follow it. They're so apprehensive. What is your take on that?
I think that's personally driven also, ma'am. Like I work closely with with the nutrition department. I started my career in Apollo with Sandhya and Priyanka, and we've been working the same way. Like even now here at Manipal at Yashwanthpur is Pavitra, and we have clear understanding with her team, and that this is what we want. And pre-operatively, all the octogenarians, if I can hold on to them for a week, 10 days, or 2 weeks at least, that's my usual timeline. Then I prepare them for 2 weeks and bring them in a better state.
Great. That's excellent. And one last question. Do you give it as a part of polymeric formula, or there are special liquids for HMB these days? One pack gives 3 grams of. How are you giving HMB?
I'm giving it as a part of a combination of a supplement that has some protein.
That has some HMB in it.
HMB, that's what I'm doing.
Okay, so we can. And you're saying 1 gram also gives us result. So probably we
I think, yeah, 1 gram, they come back, quite good. And post-op recoveries are very good. I'm not fighting frailty in a large way. 2 weeks pre-operatively, ideally, and 2 weeks post-operative. So 1 month overall through the whole process. And they do very well.
Great. Great. Thank you so much. Excellent presentation, sir.
Thank you.
Anita ma'am, you have to unmute yourself. Anita ma'am, kindly unmute yourself.
Sorry. Thank you so much, Dr. Rehan. I could understand your OT. You're still in your OT gear, and I think now you're ready for your ICU rounds. So big thank you to you.
Thank you so much.
Over to Dr. Sushil.
Okay, thank you, Dr. Rehan. So, may I know who's I think the next one would be
Avantina would be now taking over.
Okay. So I'm sorry, there was some last minute change in the order. So I'm moved up. So Ms. Anjana Nair is a consultant nutritionist from Bangalore. She has been into private practice, since more than 40 years now, with a lot of expertise and a lot of exposure in other hospitals as well. So I'll request Dr. Anjana to carry on with her talk, please.
Thank you so much for that introduction, Dr. Sushil. Thank you. And thanks to Dr. Anita and GAPIO for giving me this opportunity to be here. These kind of sessions are really important for professionals, because it not only does it explore strategies for optimizing nutrition in critical care, but it also allows exchange of best evidence-based best practices that are sustainable, that can be managed by. So it's really great. So without wasting too much of time, our next speaker is a very interesting. Actually, I found this very interesting when I saw her topic and the Dr. Avantina Bhandari.
Bhandari.
Yeah, Dr. Avantina Bhandari is a PhD in nutrition and has got some excellent professional and educational credentials. Very, very accomplished in her field. She's a chief nutrition advisor for a company. She's also a recipe development nutritionist, and the angle in which she has approached nutrition is very interesting. She's also she's also a DAAD scholar from Germany. She's a guest faculty, is also an adjunct professor from University of New York University. Now she's also authored books and chapters of textbooks on science, nutrition and sustainable agricultural practices, I think, as well as received awards and accolades across the globe. She's also received scholarships and fellowships for her for her excellent contribution to advancing nutrition science. I think she's going to speak on a very different topic, which is very interesting. And I have to say, Anita, thank you for putting this together. It's such an interesting component because most of us don't talk about this in critical care, and it actually is a very, very relevant and important aspect of this. She's going to talk about transferring ICU care, role of emotional well-being and sleep initiatives. So over to you without wasting too much time. Welcome to you, Dr. Avantina.
Thank you so much. And it's not every day that you're introduced as someone interesting. So thank you, made my day. And thanks to GAPIO, thanks to Anita ma'am for this very kind invite. And I am absolutely elated to be able to bring forth a dimension in critical care, which is often overlooked. So without further ado, I would start with the discussion. And as the topic has been already introduced, it is transforming ICU care, the role of emotional well-being and sleep initiatives. So for us, it would be a utopian world where an ICU would be something where a person is holistically treated. So the question that I start my presentation and talk today is it time to revisit, augment, and transform ICU care? So these are two scenarios. I mean, the first obviously is what we are used to seeing an ICU, and the second is something of a vision, an ICU to look like. And I will start with this question and leave it at that for you all to ponder over. Now, the first thing that comes to our mind is, why are we talking about emotional well-being and sleep? And does it really matter in the ICUs? Well, we all know ICUs are extremely high stress environments. And we also know that sleep and emotional well-being are essential for physical and mental restoration. And therefore, these restorative interventions would improve patient recovery and staff performance. Now, when we talk of care, be it critical care or general medical care, there are some things we often are very particular about. So the first is dawa, which of course is, the traditional medical system that we all have grown up to and we see. The second is dua, where we say, have faith, pray. The third, of course, extremely important, is poshan. That's nutrition, which has been very beautifully addressed by Dr. Bajaj. And there's a fourth dimension that I would like to bring forth through this discussion, and that would be Shanti. Now, that is something we don't talk about, because when we talk about hospital care, we talk about medicine, we talk about ICUs in particular, I'm sure no one thinks of Shanti. And by Shanti, I mean an environment which kind of promotes emotional well-being and less stress. Now, we all know there are challenges. And, these are staggering statistics to show that there definitely is something lacking in our system, and we need to address it so that the care is holistic. I would not focus much on, these staggering statistics, because what I'm here to talk about are interventions and initiatives. But I had to give you this stark reality, which I'm sure we all know, and there's been a big talk around it now, with showing that there's high amount of anxiety, there is PTSD, patients as well as caregivers experience sleep deprivation, and therefore all these need to be addressed. Another key aspect of disturbed sleep is directly on patient recovery. And as caregivers, as nutritionists, as medical people, we all aspire for the patient to get better soonest and recover fastest. And here I would, like to mention this thought that kind of stuck on me, which was mentioned at the beginning of the talk by Ms. Pandey. She said that we should not just look for survival, we should look for enhanced recovery, if I'm phrasing it correctly. So this is why it's important, because sleep deprivation weakens our immune system, it delays recovery, there's cognitive decline, and there's also cardiovascular stress that leads to further complications. And that's something that we don't want. Now, the idea behind my talk today is to transform and achieve emotional well-being in the ICUs, in the hospitals in general. And, there's a term called hospitality. Now, hospital and hospitality, why can't we combine the two? We've seen there's been leaps and bounds of improvement in the hospital care. The facilities have increased. We have global initiatives that are being incorporated in the hospital setup. And I think that now it is the right time to address emotional well-being and sleep into the setup as well. Now, talking about some emotional well-being initiatives that can be addressed or can be implemented or can be talked about in the medical or hospital space or critical care. First, family support programs. Now, oftentimes, what happens is that the focus is on the patient and the medical staff, the doctors, the nurses, the dieticians. In this humdrum of activity in critical care, we often overlook the caregivers, the family, friends, relatives. They are in a state of heightened stress, anxiety. What is going to happen next? What's the line of treatment? Is the patient adequately nourished? That stress level is passed on to the patient in the form of more anxiety, in the form of, having to see faces of family and relatives in a state of despair, sorrow, grief, as well as the frustration of the family, friends and relatives is passed on to the attending staff, the medical staff, the nurses, the nutritionists, and it creates a very negative environment. The frequencies, which should be calm, composed, positive, are not often so. And therefore, we need to initiate a structured communication protocol for family updates. The family members need to be adequately informed. There needs to be dedicated counseling services for caregivers, as well as flexible visitation policies to reduce anxiety. Now, I'm sure there'll be quite a few raised eyebrows because all these interventions are not always possible. And I'm sure in a utopian world, in an ideal scenario, this would be adequately addressed. But, in the world we are living in, which was very aptly conveyed in the beginning by Dr. Sushil, as in there are a lot of dynamics happening around critical care, a lot of issues to tackle. And oftentimes these things are overlooked. But of course, we can always try. Now, the second pivot in critical care is the staff. Their mental health is extremely important, which would help them, assist them, work in an atmosphere or work at a level where they would be able to give the best care. Peer support groups and resilience workshops can be formed. Access to on-site medical health professionals can be provided, as well as, besides having these mindfulness and stress reduction programs just for the patient and the caregivers, it should also be extended to the staff. Now, the third and the most important, the cynosure, as we all say, or the center of attraction of all this engagement is the patient. We need to give adequate importance to patient engagement. Because as we say that, the patient being the center of everything is the person who's actually at a level where the anxiety is profound. They are in a state of extreme stress. They don't know what is going to happen next. They see their relatives in a state of despair. They see the caregivers or the staff very frantically working around, adhering to time schedules. So for them, we need a distraction. We need them to be engaged in a constructive manner. So activities like music and art therapy, implementation of virtual reality, and training of the ICU staff to use empathetic communication techniques would be very helpful. Now, as I had mentioned in my title, that we would also be addressing sleep improvement in our initiatives for emotional well-being, because I think even as normal individuals, we know that if we are well rested, if we sleep well, our efficiency increases, we are able to perform better, we are able to focus better, there are less chances of error, and the same is true for the patients for their faster recovery, which is our goal. We need to have these sleep improvement programs in place. Now, once again, being totally realistic, it is challenging. And I think that's the precise reason we are addressing this here, that we need to make this change. We need efforts in this direction. And what could some of these efforts be? Environment optimization. We can introduce noise reduction protocols by soundproofing or having quiet hours. I mean, we've always seen, and there are areas in corporate offices, there are areas even in European trains where they have whole coaches which are quiet coaches. And something like that can also be introduced in our ICUs. There'll definitely be opposition, but we need to work towards it. Another way would be adjustment of ICU lighting to mimic natural day-night cycles, which would provide an environment which is conducive to sleep. Now we live in an era of technology, and every day newer advancements are happening right in front of our eyes, and sleep is not left behind. We can use some smart beds with automated posture adjustments, wearable devices for real-time sleep monitoring. We all use smartwatches, but some things which are conducive to the ICU can be used. The third dimension could be more like, as I mentioned earlier, the hospitality industry, more like a spa, where we have aromatherapy and calming soundscapes. We have provision of sleep masks and earplugs for patients. We have personalized schedules to align medical interventions with natural sleep patterns. Now, I'm sure in the audience, we'll have a lot of people who would be like, how is this implementable? I mean, is this even possible in the real world? To those, I would just say that, number one, change is inevitable. And number two, from being in a state of inertia, of rest, to being in inertia of motion, there's always effort required. And that's why if we discuss this often, if we bring it to the forefront, if we try to make people realize that this is also important, change will come and it will become the new normal. Like during COVID, so many things had become the new normal. For example, this webinar is only possible because people moved to a more online sphere than physical meetings. So let's be positive. Let's be in a state of shanti, as I mentioned earlier, and let's think about this with an open mind. We could also garner global campaigns by WHO. We could have international sleep health improvement conferences. We could have a data-driven care using AI-driven tools and also collaborative networks for data sharing. For all of you who feel that not much is being done, I have these examples from the real world, the world we are living in today. These have been implemented around the globe and have proved beneficial in patient recovery. So therefore, I think rather than belittling this whole idea, we need to embrace this idea with open arms and work towards it. So for example, in the USA, there are a number of hospitals which have included music therapy in critical care. So, rather than going to an opera for listening to Mozart symphonies, you are in a state of a better, calm, and a recovery mode. In Sweden, they have introduced ICU diaries where people can pen down what they're feeling and vent it out. In Australia, there are art therapy sessions. In the Netherlands, they have family engagement initiatives in the hospitals. In the UK, with technologies like Bose and Bosch and Lomb, etc., we have excellent acoustics. So they have noise reduction strategies. In Germany and India, they are using circadian lighting systems, which definitely are in the infancy states, but yes, they are trying their best. In the USA, they're also trying clustering care tasks. And in India, there's this initiative called the Healthcare at Home. And also in India, there are certain hospitals which are employing counseling services for stress and anxiety for patients, their family members, and caregivers. To cite how this has been helpful, we have observed faster recovery and reduced complications. The rates of PTSD and ICU delirium have lowered. There's improved family satisfaction and trust. And for those of you who think these are extremely, cost-intensive procedures, healthcare systems have also experienced cost efficiency because of reduced patient stays. Now, these are some journals which have studied how these interventions have been helpful. Mindfulness programs have seen a 30% reduction in perceived stress levels. Flexible scheduling has shown reduced nurse burnout by 25%. And the peer support systems have been effective in reducing PTSD symptoms in ICU staff by 40%. So these are all evidence-backed. What more can be done is so visible through these statistics. Now, all these interventions have been extremely helpful in emotional well-being for everybody involved in critical care. What is more that we can do? We can integrate wearable technologies, and rather than having it just outside the hospitals, we can try initiatives in the hospital. We can establish emotional support teams. We can have staff training on emotional awareness and advocating supportive policies and funding. And through these, what we can try to achieve is what some of these models have achieved around the world. The Dutch hospital's family-centered care model has been a phenomenal success. While I was there, I was lucky enough to experience this myself. For example, the empathy, the level of empathy. So my daughter was experienced to a traumatic experience in the hospital, and the hospital staff gave her these stuffed toys. Now that stuffed toy, although was a memory of that experience, it was also a memory that things get better. And that level of empathy towards the family member, she was not involved directly in that hospital stay, but a family member was, is phenomenal. Now, ICU diaries in Sweden have shown a reduction in PTSD. Noise reduction strategies in UK hospitals have shown faster recovery. So these are success stories. And if they can do it, anyone can do it. Holistic ICU care, as I mentioned in the beginning of my talk, is a path to healing. And we need to bring all these four components, Dawa, Dua, Poshan, and Shanti together in order to achieve faster recovery, in order to achieve well-being, in order to achieve healing. And addressing emotional and sleep needs improves all these outcomes. And therefore, let's today talk about it and make it a starting point to start addressing these issues. And I leave it to you once again to decide for yourself, is it the time to revisit, augment, and transform ICU care? Thank you so much for your patient hearing. And I would just finish off with a quote: caring for the body begins with caring for the mind and the soul. So thank you, everybody.
Thank you so much. That was excellent. We've never
Yeah,
thought of this. I think we should have involved all the management. The hospital management should be here. I think we'll get a message across. Yeah.
Thank you.
Thank you,
Thank you.
Dr. Avantina. It was a very nice this thing. Very interesting perspective, like I said in the beginning. A lot of it, some of it could be ahead of its time, especially in a country like India, where there is no healthcare system or, general, everybody pays out of pocket. So all these will be at the cost of the patient. But yes, certain things definitely can be imbibed very.
Soft
So let's
music
take the
to be
questions.
playing
We'll
ICU,
go
yeah.
ahead, Dr. Anita.
Yeah. But soft music playing in the ICU, what a great
And
message.
also,
I'm going to tell the ICU team tomorrow.
yes.
Can be implemented.
Yeah. I think some of them are very, very, very doable immediately if there is an interest to make this, some of these like she said, the caring part, and just taking care of doing something
have
that makes
these things
when the
in,
patient in the
Apollo.
ICU, the caregivers are very, very stressed, no? So it really gives something to, if you address that. So let's take the questions.
Yeah.
if anyone has questions, we are also running short of time.
Yeah, but I think it's all well
Yeah.
documented and it's actually doable. Dr. Jain, you think you'll be
Yeah.
able to push it through? We have a person from the administration today, so and an important stakeholder today.
Yeah,
So, Dr.
absolutely.
Sushin, you have to push this through.
And
Sure, sure.
therefore, I took his mention as well. You know, there are problems, of course, but there's always a start to make a change.
So the
Agree.
first hospital to implement it will be Indore Apollo.
Sure, sure. I would
Who
love to do
knows?
that. Definitely. Yes, yes.
We have in our hospital social workers. So that's another way of doing it, that if we tie up with the social workers who are wanting to give that kind of support to the family, and that also helps. So I think, yes.
Yes, so we do have social worker here who support the cancer patients and other
Patients, yeah.
patients, the
Handholdings.
transplant coordinations and all those things. But they
Support
play a
groups.
very important role. Yeah, they play a very important role in these areas. And cancer and nutrition goes hand in hand because they have to be built up before surgery or chemotherapy. So that's where they play a key role. So along with our nutritionist, definitely. Yeah.
Thank you.
So
A big thank you. Yeah, would like to close the session. You have something to say, Sandhya?
There are some questions. I wonder if Dr.
Okay.
Rehan is around. I think Dr.
So
Rehan is.
Dr. Rehan left. Yeah, Dr. Rehan and Meenakshi had some emergency, so they've left. But we can post those questions. I'll mail it to them.
Absolutely, absolutely.
Mail it to me. I'll mail it to them.
So the questions are very, very, though I would say that one of the persons.
Nothing can be irrelevant, Sandhya.
Absolutely. No,
Nothing can
not
be irrelevant.
irrelevant, not irrelevant. The question of something, I think you could probably answer that how do we look at ONS for patients who are undergoing cancer, cardiac surgeries? Do we recommend, should we recommend? That was one question that was asked here. So you being the dietitian, I thought that maybe you'd want to answer, or certainly I will pass it on to you and you can ask Dr. Rehan.
We'll ask Dr. Rehan to take it forward. Of course, ONS will be there. So would like to now close off, and a big thank you to Dr. Nandakumar Jairam, who's the president of GAPIO, for this opportunity, and the organizing team of GAPIO, and to Dr. Sushil Jain for all the help and guidance and for being here for 1.5 hours. Big
pleasure, pleasure. It's always a pleasure.
to Dr. Jain. A big thank you to our esteemed speakers, and two of them, of course, left. Thank you to you for being here, and to our moderators, to Sandhya and Anjana Nair for moderating the sessions. Really grateful to you all for accepting the invite and being here on a busy working day schedule. Thank you. I know it's late, but a big thank you.
Thank you, ma'am. Thank you so much.
Thank you.
Thank you, everyone.
All right.
Thank you. It was an
Bye-bye.
excellent
Thank
section.
you, everybody.
Bye. Bye.
Thank you. Bye-bye.